Good morning, everyone. Myself, Dr. Rakesh Solanki, Assistant Professor in Department of Orthopedics, Index Medical College, Hospital and Research Center, Indore. So today, we are going to discuss about fracture of the shaft of the femur. So, femur is the largest and the heaviest bone in the body. It transmits a person's body weight to tibia while standing, and it has an anterior bowing. The shaft of the femur is mostly smooth rounded except posteriorly. Broad rough line linea aspera exists providing aponeurotic attachment to adductors of the thigh, especially prominent at the middle third of the shaft where it has medial and lateral dips. This is the image showing the anatomy of the femur bone. The femur comprises of the head, neck, intertrochanteric region, femoral shaft, the distal femoral condylar area, that is lateral and medial condyle, and the articular surface for articulation with patella and the tibia. This is the anterior and this is the posterior aspect showing the linea aspera which has two lips, medial and lateral lip. It is more rough on posterior aspect along the midline. These are the various muscle attachment over the femur. This is a normal X-ray of the femur, full length from femoral head to distal femoral condyle. Now let us come to femoral shaft fractures. So femoral shaft fracture is a fracture of the diaphysis of the femur occurring between the 5 cm distal to the lesser trochanter and 5 cm proximal to the adductor tubercle. High energy injuries are frequently associated with life-threatening conditions due to the heavy blood loss and chances of the fat embolism. The femoral shaft is circumferentially padded with large muscles. The advantage is that improved healing potential due to good vascular tissue coverage, and the disadvantage is that difficult reduction due to possible displacement due to severe muscle pull. Now, what is the mechanism of fracture of the femoral shaft? Usually, this type of fracture involve high energy trauma, mostly occur in younger population due to road traffic accident or often result of high speed motor vehicle accidents. The low energy trauma are more common in elderly people, often result of fall on from standing, and sometimes it also occurs due to gunshot injury. When it occurs in the elderly people, it is commonly associated with trivial fall, and the patient usually has osteoporotic bones. A spiral fracture is usually caused by a fall in which the foot is anchored while twisting force is transmitted to the femur. One is not able to move the foot, and the twisting force which is transmitted to the femur leads to the spiral fracture of the femur. The transverse or oblique type of fracture pattern is due to the angulation or the direct violence to the femur, and the comminuted or segmental fracture of the femur usually result from very high energy trauma or sometimes due to crushing by any vehicle. So this can be femoral shaft fracture, can be spiral fracture, transverse or oblique fracture, and sometimes comminuted or segmental fracture. This can be open or closed. The open shaft fracture is associated with any open wound or compound injuries. Now, how to classify the femur fractures? So, type 0 femur fracture is without any comminution. Type 1 is insignificant butterfly fragment with transverse or short oblique fracture. Type 2 is large butterfly of less than 50% of the bony width and more than 50% of the cortex is intact. Type 3 is large butterfly leaving less than 50% of the cortex in contact. And type 4 is segmental with comminution. It is classified according to Winquist and Hansen classification. This is the Winquist and Hansen classification showing femoral shaft fracture from type 0 to type 4. Type 1 with no comminution, type 0 with no comminution, type 1 is the small butterfly fragment, type 2 is large butterfly fragment, type 3 is butterfly fragment is more than 50% of the width of the femoral shaft, and type 4 is comminution of the femoral shaft fracture. The clinical presentation of femoral shaft fracture, if we talk about the symptoms, then patient will complain of pain in the affected thigh with inability to walk or lift the affected limb, that is straight leg raising. There will be definitely history of trauma, RTA or gunshot wound, sports related injury like skiing, climbing in high velocity trauma. On physical examination, on inspection, the thigh will be very tense, swollen, sometimes with ecchymosis and the bruises. Now, the blood loss in the closed femoral shaft fracture is around 1 to 1.5 liter, and sometimes patient has associated feature of the shock due to this blood loss. While as compared to closed tibial fracture, the blood loss is 500 to 1000 ml. The blood loss in open fracture may be double that of the closed fracture due to the open injury. There will be tenderness around the thigh. The distal neurovascular should be always be checked as they may be compromised, leading to absence of distal femoral pulsation and absence of dorsalis pedis and posterior tibial artery. One should also examine the associated neurological injury. The position or attitude of the affected limb, the proximal shaft fractures, the proximal fragment is flexed in flexion, abduction, and external rotation because of the gluteus medius and iliopsoas pull. The proximal fragment will be typically in external rotation, flexion, and abduction deformity. The mid shaft fractures, the proximal fragment is again flexion and external rotated, but the abduction is less marked, and the lower third of the fracture of the femur, the proximal fragment is adducted and the distal fragment is tilted by gastrocnemius pull. So this is the attitude of patients affected limb in various type of fracture, including proximal, medial, and distal third of the femur. The soft tissues are always injured, and bleeding from the perforators of the profunda femoris may be severe. It can lead to the shock. And one should be aware of the fracture of the junction of the medial and distal third of femoral shaft. It can be responsible for damaging the femoral artery in the adductor canal. That is why it becomes very important in middle and distal third femoral fracture to assess the distal neurovascular status. Now, this fracture, when the patient presents with femoral shaft fracture, one needs to rule out other fractures associated fracture with femoral shaft, that is ipsilateral femoral neck fracture, which is around present in 10% of the cases, associated pelvic fracture, fracture of the ipsilateral tibia, or known as floating knee, and patient should also be evaluated for chest injury and head and associated abdominal injury, as this femoral shaft fracture usually involves very high velocity trauma. If we talk about imaging or the radiograph, the recommended views are AP and lateral view of the entire femur, AP and lateral view of the ipsilateral hip, and AP and lateral view of the ipsilateral knee, with pelvis with both hip AP view. There are 4 R's of fracture management: resuscitation, reduction, retention, and rehabilitation. The resuscitation done at the site of the trauma or emergency room comprises the addressing of the acute life-threatening condition related to the fracture or trauma, that is resuscitation. Reduction, definitive management of fracture done internally or externally. Retention, that is stabilization of fracture segment through the healing process. And rehabilitation, focusing on getting the patient back to his activities of daily living as soon as possible, and mobilizing the patient as soon as possible. If we talk about the management of fracture shaft of the femur, once the diagnosis is confirmed, following steps should be taken in emergency room before starting the definitive management. The 4R: resuscitation as per the ATLS protocol, immobilization using splints and elevation to reduce the swelling. The immobilization is done to prevent fracture from moving, and preventing the displacement, and as the fracture is immobilized, patient does not feel that severe pain. The non-operative management is used for closed fracture. Traction treated by traction with or without splint, usually Thomas splint, which is temporarily used. Skin traction is sufficient in children, and escalation traction is given in adult or if there is a displacement. Now, the uses of traction: birth to 2 years, Gillows traction is used for 3 to 6 weeks, and any older children, the Russell traction is used. If the children in more than 2 years and up to 16 years, different method of tractions can be used, followed by immobilization using hip spica cast. Hip spica plaster cast incorporating part of the trunk and limb, the long leg cast. Thomas splint. The indications of the Thomas splints are medically unfit patient, unfit for surgery, polytrauma in extremity. Advantages are stabilization when immediate surgery is not possible or practical. The disadvantages are overlap of the fracture can occur despite traction, continuing motion at the fracture site, and continuing soft tissue compromise and bleeding. The operative management is for most femoral shaft fractures are treated with intramedullary nailing where practical. This gives the strongest mechanical fixation and is the best treatment for early mobilization, that is intramedullary nailing in the form of femur interlocking nail. The intramedullary interlocking nail. The indications are all patients with femoral shaft fracture except those not fit for definitive surgery. Isolated fractures, closed fracture, gustilo type 1 and type 2 open fractures after thorough debridement, polytrauma patients in stable condition. The contraindications for intramedullary fixation are polytrauma patient in unstable condition, not medically fit for surgery, and image intensifier. If you don't have any image intensifier in your setup, associated vascular injury which requires open repair, or fracture associated with prostheses that are periprosthetic fractures if it presents with infection, occluded intramedullary canal, gustilo type 3C open fractures to avoid the risk of the severe infection. The advantages of intermedullary fixations are it is less invasive or minimally invasive procedure as it involves indirect reduction. It minimizes soft tissue damage. Fracture can be reduced. Length, angulation, and rotational control are obtained. Better biomechanical properties. Definitive procedure. It does not require secondary procedure, and rapid mobilization of patient post-operatively follows. It is associated with minimal blood loss and it gives good cosmetic results as well as good anatomical function. Now, the disadvantages are risk of iatrogenic femoral neck fracture while performing the entry for a femoral interlocking nail. There is risk of fat embolization as the intramedullary trimming is required. Close reduction may be more challenging than open reduction. Sometimes it is very difficult to reduce the close reduction to achieve the close reduction. And frequent use of image intensifier, there is risk of increased radiation exposure among the operating personnel. This is the X-ray showing fracture shaft of the femur treated with intramedullary fixation. In places without facilities of image intensifier, open K or Kuncher's lower leaf intramedullary nailing gives good result. Most is suited for a transverse or short oblique fracture, not preferred for comminuted fracture as this cannot provide adequate stability, especially the rotational stability. These are the X-rays showing long oblique fracture of the proximal part of the shaft of the femur fixed with intramedullary device. And these X-rays are after callus formation and the implant is removed. When to perform open reduction with an internal fixation with plate. Although the majority of the femoral shaft fractures are fixed with intramedullary nails, there are circumstances in which ORF with a plate may be indicated. The indication for open reduction internal fixation with plating are all patients with femoral shaft fracture where intramedullary nailing is contraindicated but the patient is fit for surgery. Indirect reduction is impossible, no image intensifier available, and early pregnancy or up to 12 weeks of gestation due to the risk from radiation exposure to the patient. Polytrauma patients with associated chest injury and caminated fractures are treated with open reduction internal fixation with plate. Now, what are the contraindications for open reduction internal fixation? Patient not medically fit for surgery, osteomyelitis, and compromised local soft tissue. The advantages are less damaging procedure, less exposure to ionizing radiation, direct detection, fracture can be reduced perfectly. The fracture stabilization with the plate reduces the incidence of embolism compared to intramedullary nailing. Fracture stabilization allows for early patient mobilization. The disadvantages are more blood loss, exposure of fracture zone, risk of interference with the healing process because of disturbance of fracture hematoma, large operative soft tissue trauma because it is an operative procedure, it requires extensive dissection and soft tissue damage, less appealing cosmetic result, there is a risk of screw pulling out in osteoporotic bone, is reduced, the risk is reduced with locking screws. This is diagram showing shaft fracture, femur fracture, treated with open direction internal fixation with plating. This is the X-ray showing shaft of the femur fracture with treated with open direction and plating. When to use external fixation? The unstable fracture, patient or soft tissues unsuitable for definitive internal fixation, and further indications are subtotal amputation or prolonged vascular deficit, salvage after major complications following internal fixation, unavailability of other treatment options, bone loss, Gustilo-Anderson type 3 and 3B and C. The contraindication of external fixation are osteoporosis. It is a relative contraindication. The advantage is rapidly applied provisional treatment, early mobilization. It is a part of the damage control orthopedics. And the disadvantage are possible loss of fixation, pin tract infection, cumbersome fixation interferes with lower limb function, may interfere with procedure for soft tissue reconstruction, high risk of non-union, malunion when used for definitive treatment. This is diagram showing external fixation of the femur. Now, the rehabilitation. It is important to start early mobilization as soon as possible and to decrease the hospital stay, decrease chances of joint stiffness, preserve normal range of motion, and return to activities of daily life as soon as practicable. The early complications are shock due to blood loss, enclosed fracture, double in open, fat embolism, symptoms occur within 24 to 48 hours. Proper splinting is required to prevent this form of complication. Injury to femoral artery, most commonly in fracture at the junction of medial and distal one-third of the femoral shaft. Injury to sciatic nerve and infection. The late complications are delayed union. Union is still insufficient to allow protected weight bearing after 5 months, requires bone grafting. Non-union again requires internal fixation and bone grafting. Malunion requires shoeraise, internal fixation, bone grafting. Knee stiffness, intra-articular, peri-articular adhesions, quadriceps adhering to fracture site. Undetected knee injury requires physiotherapy, arthrolysis, and quadriceps plasty. These are the late complications of femoral shaft fracture. Thank you very much.